So she's an osteopath practicing in Kristiansand in Norway, and she kindly has agreed to come over to give us a talk on the results of her thesis, which she has done in 2003, together with her sister Line Cote. Line Cote. Okay. And the title is Breastfeeding and its Influence on the Human Skull. Okay.
So of course I have to say I'm very happy that you invited me here. It's actually 10 years ago since we presented this thesis. It's been in some books with Torsten Liem, and I think perhaps that's why you saw this thesis, and I'm not sure how you found out about it, but I know Jane has actually heard this thesis in February, so it's okay if you sleep a little bit, because my sister did that in... It's not so often that we do. I have a twin sister, and we kind of presented this together. We lived together our whole lives until we were 18, and then we did the thesis together, so we had an excuse to meet up because she lives in France. And now I do it on my own, and it's interesting. And and Bruno, he has actually had a course with my sister last summer, swimming with dolphins. And he, of course, he thought I was being jealous. What? Not jealous. And I'm very, very jealous, and I want to do this course. So when he was saying, yeah, I'm doing some course abroad, I thought, this is the man, you know. I was sure it was you. So I grew up on the south coast of Norway. I was 10 years in the Alps doing climbing, skiing, osteopathy. And then I came back in 2000, started my own clinic. And also started ocean kayaking, which actually I really, really enjoy. I think water, it makes me get a deeper connection with myself. And I also think breastfeeding is the difficult transition from water into air. And I think this element, also with dolphins and everything, when we go into water and work with ourselves and our anxieties, it helps us to get a deeper connection with what we've been through before. And I also like to challenge myself. Look at this. This is the first time I was river kayaking, and I was, you see, in my survival brain, but I didn't go into freeze, because then you just canter. So you're in the fighting modus. And I kind of like to be, I've done a lot of crazy stuff in my life, but now I still do crazy stuff, but I'm aware about my, how to say, death angst, and trying to, finding out how to go into fight and not into freeze. And I think I need to take patience. I'm going to be an instructor soon, and I take patients in the kayaks, especially one that have deep anxieties, because very often it has something to do with their intrauterine life or the transition from water into air. So actually the process, I'm not sure if any one of you have been kayaking, but either doing the Eskimo roll or going down with your head in the dark, and you have to actually go into flexion and pull up your spray skirt and up. It actually resembles the birth process. So if anyone want to try that, it's actually in England. You have great ocean and wave riding up in Wales. My kayak is actually from Wales. But that's not about kayaking. So this is my twin sister. We're not that fat actually. This is pictures. So now you understand why Bruno didn't know which was one here. And I must admit, I don't know who is who here. And on a lot of pictures, I don't know also. I always think there's a deeper reason why you choose the theme of your thesis. And so it was for my sister and I. We were born in '68 in Norway. At that time, it was not normal to breastfeed in Norway. And our mother, she was advised not to breastfeed her two premature twins. So we wanted to know what we missed. And apparently, when I read all the research, we found 33 different research that had been done on breastfeeding. We missed quite a lot. But that's okay. When you compare after 1980, breastfeeding started to become more and more popular. Bottle feeding was started actually in 1770, more in the royalty families, and then after 1900 it became more and more popular, and then in 1980 breastfeeding took, back again. So now we're back in Norway. We're on the top of the world, both in statistic for frequency and duration. And if you compare the statistics, breastfeeding, Norway and UK, we're actually winning quite a lot. So not winning, but so this is also why I think it's important that you tell your people here it's important to breastfeed, and it's such an advantage both for the mother and for the child. In Norway, 80% of the women are breastfeeding exclusively at 3 months, only 17 in the UK. And when you do 6 months, it's 60% breastfeeding in Norway exclusively at 6 months, and only 1% in the UK. But I've heard that you have some strange thing about you have to start working very early, so of course that makes it more difficult. In Norway we have 1 year off, and actually they recommend in Norway to do 1 year off. So you have to come to Norway and get that baby. And they recommend to breastfeed for 1 year. I really think I should. No, it's okay. I'll tell you not all of the scientific studies, but some of them that I think are interesting, and also some that has been released after our thesis. This physiology of sucking and swallowing is actually not that taught in osteopathic schools, and I think it's quite interesting, and I'll show you the difference between bottle and breastfeeding. This is the muscles that are used during orophacial functions, so velopharyngeal facial muscles. And I'll just say VPF. Then to our thesis, I'll show you the interesting results, and also I think I will, because I'm right-handed. Then I can't look on the screen, but I guess that's okay. Then I've heard that you want to ask me some questions. After that, we do a little break, and then I'll show you the 3 pharyngeal arches that has to do with the visceral cranium. That are, I'm not sure if you've heard about Darraillans. He was the thesis of our director of the thesis. What is it? Oh yeah, but I think I practiced so many times, I know it by heart, and my eyes are so bad I can't look that far. Yeah? Okay, good. Our hypothesis is complex muscular. Yeah, well, I don't need that actually. I don't need that, because I have lots of batteries. So, perfect. Yeah, you read it. So breastfeeding influences the development of the infant cranium and reduces restrictions in the cranial sutures. In Thinking Finger Magoons, Magoon is talking about suckling, about the overriding and compression during birth, and he says, so suckling, which flexes the sphenobasilar synchondrosis via the vomer and normalizes the pull of the cranial membranes. Wow, this was interesting for us, and we were like, yeah, we want to try to find out what is happening here. And I'll show you, it's a little complex thing. Sucking is actually, it's like 10 minus points for you. Oh, no, I'm just kidding. Yes, the bottle. Sucking actually starts already in the 13th intrauterine week, so it's a fundamental process starting very early. This is the non-nutritive sucking. Breastfeeding is the traditional and the intuitive way of nursing our babies in all traditions and cultures. I understood in Norway it's much more an openness to breastfeeding. Even our mayor in Kristiansand, she breastfed her baby during meetings. I'm not sure if that would have happened here. Even Madonna is breastfeeding, and the reason why I show you this picture is not because she's twisting around with her baby, but she was influenced or inspired to breastfeed by Gro Nylander. You probably can't see the name here, but she is they call her the police woman of breastfeeding. She's a doctor who's written a lot of books around the beginning of the 80s, so she's actually the reason why breastfeeding has become so important in Norway. And this film is called Breast is Best. So I think you should go home and Google on that on YouTube. It's actually quite interesting. Mammals breastfeed their children. I love this picture. So look at him. Oh. Breastfeeding interacts and influences all three parts of our brain. Most of this reptilian brain that goes all the way down to the pelvis and with the cerebellum, because here you have the survival reflex when I was kayaking, but also the nourishment, sucking and swallowing. So when there is no sucking reflex or a weak sucking reflex, you really have to work on the cranial base C1 C0 because of the brainstem. It's also linked to the pituitary gland. This is important, difficult for me to say. So the prolactin, so the two hormones that are produced during breastfeeding, prolactin in the anterior part and oxytocin in the posterior. So oxytocin is also the the bonding hormone. You probably heard about Michel Audin. He's talking a lot about oxytocin. So this is the same hormone that is contracting the uterus and also when you're having sex, actually. Prolactin is actually, how do you say, depressing the sexuality, so you don't feel sexual when you're breastfeeding, but still these two hormones are important for the breastfeeding. Another important thing is that if you read Audin, I recommend you all to read Audin because he writes such good books, the Scientification of Love. You probably read that. Then you understand, we have so much intuition, and he is saying, you know how to give birth. We have it in our reptile brain. We know how to do it. And he also saying that there is an antagonistic function with oxytocin and adrenaline. So the more adrenaline, the more stressed the mother is, the more difficult, of course, the birth is, but also more difficult breastfeeding. So it's very important to make the mother, very often the mothers are super depressed when the babies come out and they don't want to show it. They control their emotions. When you control your emotions, you produce adrenaline. So very often when I treat the babies and I feel the mother is like, we have to do the breathing like Bruno does, all the way down in the pelvis, and then I let the mother tell the baby about her feelings, because she can't hide it. The baby, he smells the adrenaline of the mother. So that's when the baby relaxes, when the mother starts crying and actually recognizes her emotions. So that's very, very important. And I think we very often, there's a right ON and a condyle, and then, the baby is totally in this moral reaction, very often intrauterine, but also from birth process, and then we need to get the adrenaline down. It's also linked to the mammalian brain where the bonding takes place. So the bonding during breastfeeding, this contact between the mother and the child is, of course, more stimulated during the breastfeeding process. I see you're all taking notes. I think you can actually download this. Yeah. I think you should please look at me instead. It's not so nice to look at your, what do you call this, moons? When there is so please look at me. And then I'm sure if it's important and if I have nothing on the slides, you can, it's okay. You can also write if you want to, okay? The milk is actually optimal adapted for the best growth of the cortex. I'll show you some work on that later. The milk is a significant source of proteins, fats, and most vitamins. So the fats in the milk, they have all the polyunsaturated fatty acids that we need for the growth of the cortex. And even the fat content increases with duration. So they measure the fat content in the milk even up to 17 months, because there are some mothers just that. And there was enormous content of the fat in the milk. And fat is what's important for the growth. There's also increased growth. Lots of studies shows that. So I'm actually just showing you these studies, and you have to load them down and tell your patients about this, okay? Because there's an improved immune systems with increased antibodies, immune factors. And there's a new study that I really like that shows that breastfed children have actually increased antibody response after vaccination of HIP and this pneumococcal vaccination. But this is only significant when they're breastfed more than 90 days, okay? Exclusively breastfed. So that's actually what most of these researchers say, that it's much better to do exclusively breastfeeding. And then it's our task to help these mothers to breastfeed, so they don't need to go into this bottle feeding. And I'll show you some techniques for that later. There's a reduced risk of meningitis. It's also with long duration of breastfeeding, shown 5 to 10 years later. And reduced asthma, otitis, and respiratory infection. There's actually muscle working when we're breastfeeding, ventilating the middle ear. So that's also the reason why when you're actually nursing, you're ventilating the middle ear at the same time. Reduced allergies, diabetes, leukemia. And this is a study, you can't see it here, but it's a study done in Sweden where they mixed human milk, like breast milk, with cancer cells, and they saw that this alpha-lactalbumin, the protein in the milk, it actually kills this cancer cell. So it has anti-tumor agent. This is, of course, not done in human beings. Metabolic effect, that's important. So there's reduced risk of obesity. So this is for the children that are breastfed. Cardiovascular disease for women, nurses, babies. So what about the mothers that are breastfeeding? Because we always look, oh, our breasts are hanging afterwards and all the bad things happening, but it's actually not. So short term, 480 calories they spend more per day when they're breastfeeding. So actually they're losing weight faster when they're breastfeeding. Long term, look at these studies, just published in Norway, the Hunt study, 2012. They did this in north of Norway, examined 35,000 Norwegian women. That's amazing, huh? And they did all kind of they saw significantly reduced cardiovascular risk factors for waist circumference, diabetes, blood pressure, BMI, triglyceride, cholesterol, and this bad cholesterol, LDL. The last 3 was only significant under 50 years. But you know, you should show this to your patient. They were like, yeah. I was quite happy when I saw this study. And there are 9 studies showing reduced risk of breast cancer. This is just a German study. Better mental health when they're breastfed over 6 months. Increased bonding, as I told you. So 14 studies showed that breastfed children have improved IQ scores in cognitive development. So I was quite angry when I saw this, because I thought, wow, I could have been so intelligent. But the differences are not that huge, but they're significant, and mostly when they're breastfed more than 8 months. This is a recent study done in Egypt. They examined 53 kids at the age of 1 year. They did all kinds of neural scans and the examinations, and they saw that breastfed kids have higher neural maturation of nervous system and earlier development. This study was done in the UK in 1950. Wow. So we like this study because the Potter, he found out that breastfed children had better developed dental arches, palate, and other facial structures. So what is a well-developed dental arch? That is a U-formed dental arch like this with a low palate. And that corresponds with the good flexion position of the sphenobassler. So the palate is relatively high when you're born, and it's supposed to descend gradually at 1 year. actually synchrone with the sphenobasilar joint. It's horizontal at birth, and it's also supposed to gradually flex until you're 6-7 years old. And this, opposed to this guy, has a high palate and a V-formed dental arch, and obviously occlusion problem. Pottinger used the caliper and measured the biorbital distance, this distance and the bizygomatic distance. So with a well-developed facial skeleton, the cheekbones should be larger than the biorbital distance. And you see here the kids he measured, only 10% of the bottle-fed had a well-developed facial skeleton with broader zygomatic bones. And with the breastfed, it increased with the duration of breastfeeding. So 6 months, there were 71% that had broader zygomatic bones. Oops. Wait a second. So this study is actually very interesting, and I think this study with a little osteopathic approach to it, it would become much better. They examined 108 infants over a 5-year period from birth until they were 5 years. They measured the occlusion 2 times a year, and they saw that 72% of the malocclusion problems was in the anterior posterior plane. So the maxilla is anterior compared to the mandible, like at this. We tend to always think overbite, but overbite, it's more in the horizontal plane with the overriding. So it's actually more an overjet problem. Another study also done in America. So, excuse me, this study, I think if they added cranial restrictions, that would have been, because I think that if the base is very blocked, you still will have an overjet, even with breastfeeding. So I'll talk to you more about that later. This is a new study also showing that breastfeeding has influence on a posterior crossbite, so significantly reduced. You know what a posterior crossbite is? That's like when mandible is posterior and deviated to one of the sides. And it always goes to the side where there's restrictions. So this is posterior crossbite left. Breastfeeding had no influence on the anterior open bite here. But the risk factors are same for those 2 occlusion problems: breastfeeding less than 9 months and pacifier from 12 months to 4 years. This study was done in Japan. It's actually very difficult to measure what's happening inside the mouth because you need intraoral vacuum to aspire the milk. But they did this study on the masseter muscle. It's doing the protraction during breastfeeding, and it's significantly reduced when bottle fed. This is a little gross picture, but I want to tell you about Dr. Chancholle. Have you heard about him?
No.
He was, unfortunately, he died for a couple of years ago. He was a very dedicated surgeon, plastic surgeon also, that devoted his life to do research on orofacial function and also how breastfeeding influences all the orofacial bones. So what he was actually, he was developing techniques. They still had this Chancholle team at the University Clinic of Toulouse. He developed techniques for clefted palate and lips. So when I told you about this intraoral vacuum, it's obviously that this kid can't breastfeed. So this doctor invented techniques for these babies so they could be able to breastfeed. And he also defined these velopharyngeal facial muscle loops that are working during sucking and swallowing. We collected most of this work from Chancholle because he actually collected all the research that had been done since 1950. They originally thought that the breastfeeding was more about the tongue doing this peristaltic milking movement, but it's actually more about the intraoral pressure that is required. So this aspires the milk. And it's not a sucking process, it's more an aspirating, but we still use the sucking term here, even if it's more an aspiration thing. So Chancholle divides it into 2 phases, the depression in combination with protraction, okay? And elevation. So because we need this airtight space, he needs to have a constant contraction of the orbicular muscle here in the front to close this opening. There's an opening here. Anyone know who this sphincter is called? It's actually the sphincter that we're using when we're talking to, very important, closing the room between the nasal cavity and the oral cavity. And if it doesn't close properly, we speak very nasal. Okay, I'll say it. Wait a second. Velopharyngeal sphincter. I'll show you the muscles that are active there afterwards. And then we have a sphincter, it's called pharyngolingual sphincter, here closing the root of the tongue with the pharynx. So all these sphincters are working to close this oral cavity, and then when the mandible goes into protraction and depression, the whole volume increases, and then the pressure drops. So the pressure is, atmospheric pressure is 760, it drops down to 60 millimeters of mercury. The tongue also does a lot of work during breastfeeding. It's actually the apex of the tongue presses the base of the nipple against that all the time, and it actually also presses the whole nipple out against the palate. Opposed to bottle feeding, where it actually just presses the nipple, which is hard, and it doesn't adapt. That's also why bottle fed get a little higher palates. And it does a peristaltic movement, so it still milks out from the nipple and the breast, and then there's an aspiration of the milk. And then the elevation phase, pressure returns to its original value. Because it needs constant nasal respiration, that's why if it opens the mouth, he loses the nipple. So that's why the child here has to breathe through the nose, and that opens also the sinuses and helps developing that. Any questions to this? Have you seen this before? Familiar with that? It's actually in the osteopathy school, I didn't know about this, so I think it's quite fascinating. I'll show you difference between bottle feeding to the bottle feeding. It can actually, there's no need for this decrease in intraoral vacuum, because only a minimal subatmospheric pressure is enough to get the milk out of the bottle. That's why it doesn't need to use all these muscles that I show you here. He can also open the mouth, and the bottle doesn't fall out of his mouth, so he doesn't need to respire through the nose all the time. And the jaw movements are less, so less protrusion and protraction and depression. The tongue is actually doing a very different movement here. It's going more up and down like a piston. It's less tonic, and there's also less propulsion of the tongue and the lips during this bottle feeding, And all the muscles are working less during the bottle feeding process. Oops, sorry. So what muscles are working here? What muscles are actually flexing the sphenobasilar joint, as Magoon postulates? This is the key muscle here, the superior pharyngeal constrictor muscle. It's part of the central chain, the pharyngo-prevertebral chain. It inserts on the base of the occiput on the pharyngeal tubercle. Was that right? It's very difficult for me. And then it inserts on sphenoid, on the pterygoid, medial pterygoid process and humulus, and on the mandible. This muscle is actually coordinating all the other muscles in the orofacial functions. When we're talking, when we're swallowing, sucking, eating, everything. And it has 4 important extensions. This is the one who goes up to the middle ear, as I told you about with the otitis, ventilating the middle ear. Then we have the velopharyngeal sphincter here. It's working together with the levator veli palatinum. I'm sorry I have to say this in Latin. You understand this? So you're German, you understand. And this sphincter is closing the passage between the nasal cavity and the oral cavity. And then we have another sphincter, the pharyngolingual sphincter here. So the extension is called glossopharyngolingual, this muscle here. It's working together with the constrictor medial and the hyoglossus for the swallowing, and also to close this between the mouth and the pharynx. And then the most important extension here is the long loop, going from constrictor over to buccinator and the orbicular muscle. And this is actually constant during sucking and swallowing. It's constant contracted here. And this muscle chain is working antagonist with the tongue that is pressing the teeth from laterally from the inside, and the long loop is actually coming from the outside and compressing from the outside. So that is the main, an important factor that breastfed children have less occlusion problems, because they're actually modeling the dental arches. Again, this is seen from above. So the constrictor from behind, then going up to the middle ear. Here you have the sphincter to the velum, here to the tongue, and the long loop. And here you can see so the tongue muscle are actually, these two are synchronized with the muscle called palatoglossus. So he is actually opening the root of the tongue when you're swallowing. I know this is a little much for you, but I still think it's interesting, and if you have it on the slides, you can look at it later. This chain is also working with the tongue chain during the swallowing process, and when you start doing mastication, it's strengthened by myelofibrillos here in the front. Good. Okay, we did a correlation study, by the way, to examine our palpation. So we did I think 5 babies, and we did all the parameters and evaluated them with a third osteopath. And we are identical twins, so we had actually 84% identical observations. So I'm not sure, Jane, what do you think? That was good, wasn't it? We examined 60 infants, 30 in Norway, 30 in France. And we did first evaluation postnatal day from the 1st to the 10th, and second evaluation between 8 and 12 weeks. So we only evaluated, and we didn't do anything, just evaluated. And it's kind of hard for us osteopaths to know, whoa, he has like a super problem here, can I just leave this for 3 months? But we did, and we're happy we did it, because then we saw what's happening with the restrictions over time. We examined the cranium, the mobility of the sphenobasilar joint, and the pre-osseous elements of occiput, so the condyles, rotational squama. Then we did all the craniofacial sutures and the pelvis. So the pelvis, we didn't find any real results in there after the second evaluation. Like Potenter, we did this caliper to just have an objective measurement. So we measured the bizygomatic and biorbital distance. Because we wanted to be impartial about our results, we did not know about the feeding method until the second evaluation. That's why we got unequal numbers, because there were more that were breastfed. In Norway, I think all except one was not breastfed. So that's why we had different numbers in the group. And bottle fed only 12. So this group we had to add because we wanted clean nutrition. So these were the ones that tried to breastfeed and they couldn't do it. We included this in the whole thesis, but I won't show you the results. But these guys, they had big problems because they were not able to breastfeed. So 90% of the Norwegian were breastfed, only 34 of the French. I'm not sure you have the same, how you feel. What do you feel about the breastfeeding?
I think that the duration, the main duration, 3 months,
yeah.
Not 1 year.
Yeah.
And I think the percentage is getting higher.
Yes, I think so. My sister is really doing a lot of lectures in the La Lèche League, and so we got significant results of 70% of the facial sutures with the reduction of the restrictions, between the two evaluations according to this T-test. We divided the sutural lesions up in 3 segments because they had similar results by the second evaluation. So in the face we had all the significant results with reduction of the sutural restrictions. In the median segment there were not that much change, and in the posterior segment we had a lot of increase of restrictions after the second evaluation. We wouldn't expect that, so we were quite. So this is just to show you one of the significant results. We had significant results on all the the facial sutures except the right frontal zygomatic. So we did evaluate in membranous lesion and osseous, and then by the second evaluation. The average for both membranous and osseous was 9%. Oops. I wanted to show you what happened in the posterior segment and also the occipital base. So we learn in osteopathy that right side is mostly compressed. You probably also experienced that after birth when you treat them right after birth, with often clockwise rotation like Freiman describes it. And you hear the right OM is osseous blocked compared to left OM only 26. And then by the second evaluation, so we were quite surprised when we saw this, that there was a transfer from both membranous and also increase of the osseous lesion by the second evaluation. So we got 63 restrictions on the left OM, osseous restricted, so no mobility. And then we had on the left condyle 23 membranous. So we think that the infant cranium wanted to create symmetry. So it was blocked there, then he tried to block on the other side. So that's why we often find kids that have blocked on both sides. So that's, you know, not so important to treat a left OM that is blocked osseously when the right one. So you first should do the right side first, because this very often disappears. It's just a compaction. And this had influence on the sphenobacular joints because we got results that we did not expect. We had a lot of transfer between the two evaluations. So we couldn't do any statistical results because we had, very often we had, for example, a right torsion, right condyle restricted on the right side, and the second evaluation, then the left condyle was restricted, and it went from side bending rotation to on the left side. So it seems that the sphenobacular joint moved actually around this blockage to also create symmetry. So that's why I think we should not always jump to the sphenobacular joint. We should really decompact the cranial base with occiput first. Of course, it's important to evaluate sphenobacular joint, but I think very often it actually adapts to osseous lesion of the cranial base, the occiput. However, there were 50% of the breastfed group that restored normal mobility of the sphenobacular joint. It's not so much, but it's still a percentage. So there was both reduction in osseous lesion. I know this was only one child. He had a right torsion, osseous, but he didn't have any blockage on the occiput. And then the kids that actually had this reduction of the sphenobacular lesions were obviously most membranous lesion, but they did not have any osseous blockage of the occipital base, nor they had a lot of sutures, osseous lesions in the wall. So if they had overriding or overlapping, this really also affects the sphenobacular joint. Foul fed, they actually had an increase of lesion from transfer from membranous to osseous. I want to talk to you about that later, so you don't need to ask questions, but this is also, if you see 75% and then it's 83, and there's, from here, there was a, restricted, but, it's not totally restricted, and then afterwards they had no mobility at all. So we did this caliper thing, and we saw that both groups had the bizygomatic distance were 3 millimeters larger than the biorbital. By the second evaluation, as Pottinger found out in 1950, they were only increased in the breastfed group with 0.5 millimeter, is not so much, but the bottom-fed group increased only here in the biorbital distance. I'll explain to you later why that happened. Have to remind you about, so we had our significant results here and a little bit in sphenobasilar joint. And all these marked with blue, they are has membranous ossification, and they depend on extra osseous stimuli. That's like the atmospheric pressure and the intracranial fluids from the inside, but most importantly in the muscular functional muscle activity, and obviously the first year, sucking and swallowing. So all these muscles are working with the constrictor muscle as the chain muscle. So contraction leads to compression, elongation leads to decompression. Just to interpret the results of our thesis, or mostly the research that has been done and trying to explain why they have less overjet, the vertical branch is mostly stimulated through mastication, but it's actually this retracted mandible, because all kids are, you see when they're born, they have a retracted mandible. So this is important that they get it in the front to prevent occlusion problems. Depression is done by the suprahyoid muscles. They're working all the time to get the, doing this. Protraction is done by the masseter muscle, as I told you, and the lateral pterygoid muscle. And these, according to Darraillans, they actually also pull on this ligament, sphenomandibular ligament, and stimulated the growth of the horizontal branch. I see you're yawning there. Is it too much? Okay, good. I think that the air could be a little better here, but that's... Okay, so to our significant result in the face, why do you think we got these results? We were, whoa, what's happening here? So we have to remember that this muscle is constant active, the orbicular muscle with the vaccinator. And I'm not sure if you're aware of this, but this is the inserting point. It's a fibrous meeting point for all the other facial muscles. So when the child is sucking on the breast, the lips should be protruded like that, and then the jaw like that. The tongue is working in propulsion too. So everything is pulled. So we think this pull on these muscles are actually the reason why we got our results. So reduced restriction in this suture, in this suture, in this suture, and as well as the increased growth of the zygomatic bones. So if you tell your mothers your kid would have better, I would say they don't need any Botox in there. Perhaps they will breastfeed. No, I'm just kidding. So what happened to the sphenobasilar joint? Why is Magoon saying this flexion sphenobasilar? We talked to Chancholle about this and Bernard too, and the intraoral vacuum that is created, and that is quite high, it actually aspirates the pellet during the first year. And this, a low pellet, it's a sphenobasilar flexion position. So we think that this actually helps the flexion position. Then we have the activity of the constrictor muscle. And during sucking, so these muscles, they're working with changing, the constrictor muscle is changing fixed point after if it's swallowing or sucking. So if it's sucking, the fixed point is inferior, and it pulls here on the pterygoid process posterolaterally. And this tilts the sphenoid into flexion and also the sphenobasilar. Okay, so infant sucking stimulates cranial flexion. I'm not sure if you like this, but I like this flower. It's like the unfolding of the cranium in the flexion position. So what is the infant swallowing? Anyone know? So when grown-ups are swallowing, I want you just to swallow with occlusion and try to just feel. Close your eyes and try to feel what is happening with my tongue. Okay? You feel it presses with the root against the pellet. And then I want you to swallow like the infant does. So they swallow with non-occlusion. So do the same swallowing, close your mouth, swallow without occlusion. It's very difficult. Anyone who has something with the tongue. If you press the tongue like they do against the back of the teeth, try again. Yeah, so you see, you can swallow. But do you feel the difference in the tongue? The tongue goes backwards. So what's important that the infant palate is in line with the basic occiput, and the apex is in the front, so the fixed point is in the front, and by the grown-ups it's in the back. And here it's actually stimulates cranial extension. Good. This again, I just put this slide up so you can see what's actually happening, but it's actually mostly this tongue process that is different. And the difference between swallowing, bottle feeding and breastfeeding is only that there's less proportion of tongue, lips, and the jaws. Whoops. So our hypothesis seems it's correct. It influences development of infant cranium with the facial growth, reduces restriction in the facial sutures, and in the sphenobasilar joint. Our thesis showed that the function influences the structure. I want to read the quote for Still. We all need to use some of Still's work, don't we? So, the body has within itself all the resources to heal as long as the pathologies do not reach an irreversible stage. So actually this is the whole thing of our thesis. So if the cranial base is too blocked, did not change the sphenobasilar joint that much, a little restriction still reduced on the facial sutures. So this is what interests me a lot, and I hope if somebody wants to do research, I think this is very interesting. Look at the increased osseous lesion between the two evaluations. So here's just the percentage. Right frontosvenal, the right coronal suture increased with 50%. The right lambdoid, right OM, right condyle. What do you think happened? So there's some difference in our thesis, and now I'm starting criticizing the thesis because we did some mistakes. Oops. Yeah. Because this is to Jane's, I was not allowed to examine the babies in hospital. In Norway, it's not recognized yet, the osteopathy, and when I applied for a grant, they said, we don't believe that you can palpate. Okay, so I had to do all the examination in my clinic after the 5th day. My sister, she could do it right away in the clinic, so she examined right after birth. So I think this is also the reason why we got these results, that because the the infant cranium is very fluidy in the beginning. Not sure, I think you can work in the hospitals right away, can't you? No, I've heard that. Really? I always say, oh, in England, everybody can go into hospital.
Well, we can, we're invited.
Oh, okay, yeah. But at least she did it right away. So there's like 75% of the bowel fat were examined right away. So I think that some of these restrictions, they have not yet developed these sutural restrictions. And French, they had much more difficult deliveries. Look at this. The dilation phase is 10 hours difference between the group.
Wow.
Wow. So I must say, there are more primipair, also the ones that had their first baby in the French group, but still, look at the epidural. You know, 75 in the bowel fat. So in France, if you don't say anything, you get an epidural. Correct? That's what my sister said. In Norway, you have to fight for an epidural.
90%.
90%, yeah. So what's happening with epidural? It's actually lowers the vitality of the infant.
And in England, more than we were expecting, as of right.
Yes. And sadly in Norway too. So, but here you actually see the sphenobasilar compaction, 75%. So there's like no movement, no vitality, but there is still mobility. After second evaluation, osseous compaction. That's quite a change, isn't it? And here you see it again, membranous to osseous. So I want to show you Viola Fryman. I think she nailed it here in her collected papers where she says, if the infant's vitality is low, this is when you have epidural, or forces of labor disproportionately strong, the cranium is incompletely re-expanded by the infant's activity. So I think the fact that they had epidural and they did not have the breastfeeding, flexion, extension, that's why all these restrictions occurred. And then, I know he would ask me if I would do this thesis again, definitely. It opened a lot of doors for me. I've done a lot of lectures in hospitals, for midwives, physiotherapists, and in Norway it's not recognized. So for me, yeah, can you speak about breastfeeding? Yeah, but of course when I speak about breastfeeding I have to speak about osteopathy. So it's a way also for me to spread the gospel. If I would do this again, I would of course done bigger groups and equal number in the groups. I would have excluded this mixed group. This could be a separate study because the people that can't breastfeed, they have enormous compactions on the base. Then I would have done 3 evaluations. One right in the beginning, then one after 10 days to see if the epidural has any effect, and then a 3rd evaluation long term to see if breastfeeding, because now we can't really say is it breastfeeding or is it the epidural. Yeah. And I would include the diaphragm and the sutures of the heart tower. Good. So I can take your questions.
Thanks, Gunn. Yeah, we have time for 2 to 3 questions.
Yes.
And then we have to move on to the practical.
Yeah? Oh, he was first. Okay.
But on the immunity issue, is there any work?
Excuse me, what do you say?
On the immunity changes, is there any work done on breastfed milk as opposed to bottle-fed milk, or is it just breastfeeding as opposed to bottle-fed milk? So if the woman uses the pump, do you get the same immunity, or is it just from the breastfeed?
Oh yeah, you definitely get the same immunity. I think so, but it's just breastfed. I think there's no study done on that. But you know, you can go on this PubMed and look. But I don't think, because very often when they pump, it's not a clean way of, because they do with the bottle. So I think they do breastfeeding, and it's actually interesting. But I'm sure, you know, the content of the milk, there's much more immune globulin in that milk. So of course it's actually the content, the chemical thing that it's influenced the breast. But of course in osteopathy, when we say we have a good mobility of sphenobasilar, it also indirectly improves our immune system.
Yeah.
Well, the whole sucking action is going to work in lymphatics.
Yes, and the diaphragm and was that so? There's not yet any studies on that I know of.
Okay.
Yes.
And have you any thoughts about the effect of tongue tie?
I will show you that later,
Okay.
and I'll show you some techniques for that.
Great.
Anyone? Yes.
I have questions. I assume, but not sure, whether you excluded any assisted deliveries, so either forceps or TUS or...
In the study?
Yeah, because it says about the length of labour, but...
Yeah, we did correlation study on all that. So the stimulated, how do you say, the one that was induced, the labor was much longer. But you know, that was not so important in our study. We did cross-correlation. I can show you that if you want to.
The actual second stage, so whether they had to have forceps or 1, 2, 6.
Yeah, we included actually all those, but we didn't have that many. But we done. I can show you the list we included. So, but of course that also increased the restrictions. But that was, you know, mostly the French babies that had more difficult deliveries, more forceps. In Norway they also use forceps, of course. But I still think that, you know, when you see a baby that are overriding here, you really need to work on that immediately, because that really also you know, blocks the whole sphenovascular joint. So forceps and what do you call this? Sucking? Vacuum?
Ventouse.
Ventouse. That's French, isn't it? It sounds French to me. But your question was if we included the ventouse in the... Yeah, we included everyone except clefted palate. And of course, after... I think we should have excluded the one with sucking difficulties, but we made separate statistics in all groups, so it didn't change our results. But we took breastfeeding and bottle feeding as... That's what I wanted to show you here. Yes?
Would you include in a future study anything to do with the postural situation of most bulk-fed babies are just fed on one side constantly, whereas breastfed babies are fed both sides and in different positions, something like that.
I'll show you the position afterward. What's important when you do bottle feeding, you really have to copy the physiology of breastfeeding. And I'll show you the positions. And you have to really tell the mother to do both sides.
Yes, but it wouldn't be hospital.
Okay, I think that's it with the questions. We have to move on to the practicals now.
So the practicals, I'll do a little bit of the sucking problems. I'm not sure, do you treat a lot of babies that had sucking problems?
Yeah.
Yes. So I hope for the men here, very often when I do the lecture, I feel the man is like, and the women are like, yeah. But you feel included? Yes, it's okay?
Sure.
Yes, good. And the babies we treat today will be in a better health tomorrow. I'll do some practical approach on breastfeeding with positions, then the reasons why for difficulties, and then I'll do the sucking test and what you have to be aware of when you test the sucking, how it sucks. And then the pharyngeal arches of Bernard Darraillans, only the ones that are influencing the face. Are you aware of this woman, Denys-Struyf? That yes, you are? Yeah. She actually helped us a lot. She's the one that invented the muscle chains, the AM, PM. She helped us a lot. Unfortunately, she's dead now, but she wrote like 50 article page to our studies, finding out what muscle chain are working during sucking and swallowing. So she was a lot of help. My sister went to all her courses. The two chains that are working is the pharyngo-prevertebral chain, the central chain. This is the velopharyngeal muscles, together with the AM chain, the muscles of the tongue, and the suprahyoidal muscles. So this is why you have to actually be aware of the position to stimulate these chains. This is Denys-Struyf. He says the mouth is the meeting point where all the muscles chains join and synchronize during breastfeeding. So here you have the AM chain, then the central chain, and PM chain, and then the mastication chains on the side. Do you know these chains? Yeah, good. So the lingual chain, so there's a lot of, it's a tongue muscle, the long loop like orbicular, buccinator, hyoidal muscle, styloid. So this chain is important. It's structured intrauterine and also the first year. It's linked to the mother. The central chain, so this is the most important chain here because this is the velopharyngofacial muscles. This chain here, it's the one who stabilizes C0, C1, and this should stabilize this during breastfeeding. So that's why it's important the child should have a neutral position of the neck. Not like this, not like this. Okay, it should be neutral. And this chain, as you then know, it changes a fixed point. So when there's sucking, it has fixed point inferior, swallowing, superior. And it's dynamic. This chain, it's only going to balance the other chains during the breastfeeding process. It should not be active. And what you see in your clinic is that a lot of the kids have too much PM, infants. Yeah, like this, right? Yeah, and the PM chain, the embryologic, the surenal, or the, how do you say the surenal? The adrenal glands, they're a part of this chain, So when there's adrenaline, when the mother is stressing, oh, I have to give birth, and all her death angst is coming up, the kid go into PIA. And that's, really have to work on this to get also a balance, because it's actually the chain in the front which should be used mostly in the beginning, especially during sucking. Whoops. Sorry. So the child, to make the central and the AM chain working good together, the head should be neutral. Can you see this? Yeah? Yeah? Okay. Just, this is the position you should avoid. It shouldn't have the hands to the side, otherwise you have a rotation to the other side. You should copy the physiology. So the lip should be outside, it's important, and on both sides. That's a good thing. So in hospital they don't say that actually. This, I really like this. I had this, my dad made it a bed for me when I was breastfeeding, so you can just carry the baby over, breastfeed, back. Do you know this bed? Yeah. Oh, you know that? Okay. No. So just to remind, we don't need to go through this, but these are the nerves, the hypoglossus for the tongue muscle, vagal nerve. We tend to forget that this is the motoric for the velum, pharyngo, and larynx muscles, and the sensoric for the pharynx and the tongue. So when there is breastfeeding problems, you mainly have to work on occiput and also temporal and sphenoid, but mostly on the back here. Oops. To do the sucking test, there's I can't remember his name, but there's a French guy. He said you should try to test sucking like this. I don't like that. You have to change the finger. First you strike the cheeks, the lips, so it opens the mouth. You put the finger inside, and then you have to check if there are any noises. So if you feel noises in the front, that's when they can't close the orbicular. And very often they put like the tongue underneath. And then you have to work on the stylomastoid foramen, because that's where the facial nerve goes out. It could also be the constrictor muscle, because it works always with the constrictor muscle. If the noises, you feel the noises in the back of the mouth, that's those two sphincters that are not working well. So glossopharyngeal or the vagal nerve you have to work on. If there is not a sucking reflex on the base, because of the reptile brain. So this is the tongue tie. The tongue is actually also, how do you say, started at the 4th week intrauterine. And when it's of stressful period around these 4 weeks, very often you get this tongue tie. The tongue tie serves as the axis for the anterior growth of the tongue. So that's why the tongue, this is really a problem with breastfeeding, because it can't put the tongue against the nipple. I've actually, I think I've about 10 babies I managed to do this functionally, to work on the hyoid, like the techniques I want to show you later. But when it's really tight, yeah, okay. The mandible, you have to work on the compression on the cranial base. The torticollis, it's also very often they can only breastfeeding on one side. If you tell them to keep both the hands on each side of the breast, it helps a lot. And of course you have to work on the mandible. This technique I like a lot. I learned it from Viola Fryman. Especially the one who has a lot of tension on the central chain. Instead of putting on the shoulder and then like this, you turn them around. You put the right hand like that, other hand on the stomach and the jaw, and you do a slight tension, and then you work your way up with the legs. And I always show it to the mothers, and then like, yeah, it's so much easier to get them to. You know this? Good. So this is just where I think that if there's stress, I always tell the mother, don't eat any sugar, gluten, or drink milk. Yes. Yes, and I own this Camirand's diet, and I really like it. And there is a study showing that the moderate low-carb diet increased the fat in the breast milk. Anyone on this diet? Have you tried it? Yeah. So
What diet do you mean?
it's the modified Camirand's diet. So you eat berries, no gluten, lots of vegetable fat, no bread. So when there's a lot of thrush, I always tell them to eat this moderate low carb diet, and it really helps for the candida because there is no sugar. Good. So I treat the baby. First I always examine the baby, and then I treat, and then afterwards I test the sucking, and then I treat. I always end when they're breastfeeding, and then it's really nice to see how, you know, the sucking is working much more efficiently. And I also, when I work, I saw some in your slides that you always put the finger in the mouth, and then to help to make a fixed point. Okay. You know, the pharyngeal archer, you're probably familiar with that. Bernard does it a little different as the original pharyngeal arches. This is more functional part. If I can just show you this, and then you practice fast afterwards, okay? So the suprapharyngeal arch, that's the maxilla, zygoma, and the palate, and they're embryologically they're made of the same as the cerebellum. And so what's important, the first year the cerebellum should go posterior, and it almost tracks the whole facial skeleton into flexion. So what we don't, when we have a cerebellum who's like very tight, and then you feel overjet and everything is in the front. So this is very good technique to help people with overjet problem. So what you do, you put do you know this technique?
Do we want to do it now practically? Because we
Yes.
only have 10 minutes,
Yes.
so maybe just do this technique.
Okay, but I'll just do the principle. So you just put the posture end here, the fifth finger is all the way down to C1. Then you put it on zygoma or the maxilla. You do hologram, and of course you're aware of the breathing, like Bruno says. Then you go into ease. Very often it goes into side bending, rotation, and you have to visualize the cerebellum, fourth ventricle, and all these are embryologically in the same, how we say, arch. And then when it expands, you feel the posterior hand go posteriorly, and then the palate descending into flexion. Okay? And I also use this as, how do you say, palpate what sutures are restricted also. It's a nice diagnosis. Then you go into the posterior hand in the same, but you go onto the tongue, the position of the tongue with the orbicular muscle. The tongue is actually supposed to ascend during flexion, and the cerebellum, the tentorium, is going to descend. So this is the one you want to have in the end. Very often, tentorium is up, the tongue is down. So you have to work on this axis. So you have the posterior hand on occiput, this on the commissural labial, which is also the axis for the tongue. You go into first you do hologram, go into ease, and then when it relaxes, the tongue should go down, and tongue should go up, and the whole tentorium down, like this. Okay? But most important is that very often the tongue is to one side. Then we do the maxilla and the hyoid, the third pharyngeal arch. So you have one hand posterior, but here you have to put the fifth finger further down. So you put it on between C1 and C2, because they are structured from they're also structured from occiput, C1 and C2. So you put mandible. We only do the horizontal part, and you visualize the sphenomandibular ligament, the occiput, and then you do your hologram into release, and then what's important, you pull a little bit, and then you really want mandible to go into retraction, okay? Up. So this is, and then you do the same on hyoid. Hyoid is at birth about up at C0, C1, and we want this to go down around C3 at the first year. So we want hyoid to get down, and very often hyoid is up, and with almost, if it's a functional tongue tie, you can really work on that. If it's really restricted, you can't do anything. So then you have the hand on occiput, C2 here on high wheel. Very often it's up and to the right, rotated, you go into ease, and then still point relax, and then you really have to pull on this a little bit inferior, just a slight. Okay? You want to try this? I think perhaps you can try this. I put the picture of all of them, and then you just try into group, and I don't direct you. Is that okay? Yeah?